Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills. Now, here are your hosts, AACN's Chief Clinical Officer, Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Vicki Good, and I am joined by my co-host, Andrea Schmidt.
This is Andrea. Hi, everybody. Welcome to all of our listeners.
Today, we have the tremendous opportunity to talk with Yolanda Smith, a nurse who took a devastating personal tragedy and transformed it into a moment to improve nursing. I've had the honor of meeting Yolanda a few months ago. And before we dive in with our listeners, I really want Yolanda to introduce yourself and share your nursing journey.
Thank you, Vicki. It's a pleasure to be here today on this podcast and give a little bit about my background and also share my story. So my background in nursing started, I was a critical care nurse, so I was also an AACN certified critical care nurse, associate director for cardiothoracic services, so that's where I worked in critical care. That's my clinical background. I had the opportunity to also teach in the School of Nursing. I went on to have my own business as a legal nurse consultant, so I know documentation very, very well. And then I proceeded to be the assistant vice president for clinical operations. And my last position was as a CNO for a hospital healthcare system here in New York City.
That's great. Thank you. As we mentioned in our introduction, you took a significant personal tragedy and used it as a catalyst to improve patient and nurse safety. Would you share with our listeners how this tragedy led you to focus on patient safety?
Yes, so the critical situation, Andrea, that happened was my dear family member's death. It was a failure to rescue, and that was a preventable error that could have been definitely preventable. With my background as a legal nurse consultant, I had the opportunity to review my family members' medical records. I never thought the day would come that I would be reviewing my own family members' medical records. From that, I was able to determine the deviations from the standard of care and the physiological changes that had been experienced that were actually documented and that was not treated in a timely manner. Ultimately, my family member died after elective surgery. So now I use that as a catalyst to be where I am today and to use those experiences to be able to advocate for nurses, to teach them, and also to be an advocate for patients so that when they're in that situation, that they would have a voice to communicate. And when you're observing physiological changes that are abnormal, to escalate those changes. And we'll go on to that, I guess, Vicki, in more detail.
And I think the thing that, as I've gotten to know you and listened to your story, I think is so important for the listeners to also realize is the context in which all of this was happening. The COVID-19 pandemic had started. You're working in the epicenter of New York City. You're also a CNO of a healthcare system, and that's not enough. You're also completing your DNP. And then now you're processing the death of someone beloved to you. And I can speak for myself. That would be enough to send me underneath my sheets and not want to come out. So how did you take care of yourself during this time and then have the strength to pull it into something positive for everyone else?
So thank you, Vicki. Well, I could actually say, so this happened to my family member 2 years ago, died 2 years ago. I will tell you, actually, 2023 was a blur for me. So when you're thinking of putting these pieces together, you're thinking initially of somebody passing away, the things that you have to take care of from that perspective. And then I was also finishing up my DNP. Actually, my family member died after my graduation. We were planning our graduation party and it never took place. And then during that time, I kept getting these emails about being a CNO again. And I think, Vicki, you had mentioned being a CNO yourself. during that pandemic, I also was tasked with creating COVID isolation hotels. So in New York City, we stood up 6 hotels in that 2-year period from April 20 to March of 2022. We took care of 35,000 people with COVID. Had no
Wow.
previous experience. I think my leadership
Wow.
skills really had a chance to expand. And that's when the whole well-being component kind of took place for me, because I was looking at the middle management and the impact the pandemic was having on them. Nobody really was thinking about leaders and the impact the COVID pandemic was having on us. The real focus is on the frontline staff getting beds, to be able to get those patients in that really needed that care. So I took 23 as a time to become certified as a positive psychology well-being coach, to use that. I mean, I have many years, over 30 years of clinical and critical care experience, but bringing that well-being component into the mix, I think also helped. And I also took a course of being chief wellness officer. So bringing the wellness component into the well-being, into the critical thinking, clinical judgment, all those skill sets that really impact a nurse's ability to think clearly and to think of what to do for this patient as they are deteriorating. Walking, I think, was something that I did. Sometimes I feel like I just was walking aimlessly. I walked my neighborhood. I walked near me, Prospect Park, about 4 miles. I was doing that like every day. And sometimes I don't even remember walking. I mean, you're doing it because you're in the motion of doing, and then you realize, you've accumulated these steps. And meditation, those are the things that really helped me to and journaling, those things, and writing down what I was experiencing. So now I can reflect back on that time to see where I am today versus a year ago.
I don't know how you accomplished all of that. But first, I want to say I'm very sorry for the loss of your loved one, that you had to suffer that tragedy. But to be able to suffer that tragedy and do everything that you did is really quite the accomplishment. All of the classes that you took to help with well-being really led you to develop programs to help nurses provide safer care through innovation and holistic well-being. Can you share with us what the focus of those programs you developed were?
Well, the first program that I developed, it's called Professional Wellbeing in the Practice Environment, Wellness-Centered Nursing Leadership, because I felt like during that pandemic, that was the sandwich of leaders that were kind of missed. Like the focus, like I said, was previously on frontline nurses. So that program has 13 contact hours through the American Holistic Nurses Association, which I'm a member. So in that program, nurse leaders will have an opportunity to identify a well-being issue within their respective departments, and then implement a quality improvement well-being project. And I will be giving them coaching. Actually, I just started the program last week, so I'm doing it live. I was expecting 5 nurse leaders, and I wound up having 12. So,
wow.
yeah, it was really a good experience. It hasn't finished, but it's a 4-part series that I'm doing, and that's for the nurse leaders. And then the one for the frontline nurses is called "The Nurse's Guide to Thriving: Building Resilience and Self-Care to Prevent Burnout." So now looking at that frontline nurse, what that nurse could do to better take care of themselves and increasing their resiliency, because when nurses are not resilient, they're burned out, they don't have clarity of thought, their critical thinking skills are not where they should be, and that's where errors wind up taking place. They're fatigued, so they omit things that they may not necessarily do. So that's why that program was created. And the other 2 programs are entitled Essential Nursing Skills Workshop, Critical Thinking, Clinical Judgment, Communication, and Assessment. So when we look at failure to rescue, those are the key skill sets that nurses need to be able to better manage their patient population, or the patients that are assigned to them. And lastly, mitigating legal risk, maximizing care, patient safety, and nursing failure to rescue prevention. So through those 2 programs, we do a lot of unfolding scenarios, so that I give them information. Now and then they do like an SBAR, they do an assessment, so they're able to put all those critical elements together to prevent that patient from deteriorating. And then we do a debriefing at the end. And all of those have contact hours.
I've worked, many years in patient safety arena, and there's main contributing factors to leading to failure to rescue in the healthcare setting But have you found that one contributing factor is more prevalent or predominant in the nursing profession than others?
I would say yes, Vicky, failure to recognize. So when we look at a patient, typically, nurses, depending on what type of unit they work on, the frequency with which they take vital signs, the frequency with which they're doing nursing surveillance on those patients, monitoring those patients, recognizing, because although they have the rapid response teams or the emergency teams, they can only arrive if you've identified that there's a change in a patient. So if you're missing those key things, and then, there's called the afferent arm, and the afferent arm is really from the nursing perspective, what the nurse is recognizing that this patient is deteriorating. What can I do now to prevent that patient from, further deteriorating? And then, before you call the rapid response teams, I would say failure to recognize would be the key one out of the four. Did I mention the four?
No.
Oh,
No.
I'm sorry. So the four would be omissions of care. So when nurses, there may be staffing issues or workflow changes, new graduates, novice nurses, so they may omit care, not delivering care on time, not doing care completely, patients getting ready for discharge, not doing patient education on that particular patient. Patient winds up being readmitted to their unit, or not doing all the vital signs. The key vital sign that nurses usually overlook is respiratory. So nurses are very keen on taking the blood pressures and putting those numbers down, but actually taking a patient's respiratory rate for a full minute, looking to see the patient's having, good ventilation and movement of their chest. Sometimes that's the one vital sign that's usually omitted. So it's omissions of care, failure to recognize, which I just mentioned, which is the assessment component, failure to escalate, that communication component, and then also ineffective clinical decision making. So out of the four, I would say recognizing, because typically when a patient deteriorates, it could be hours or a day before that happens that nurses usually overlook it.
So it's really early recognition too.
Yes.
Yes.
Yes. So for me, when you think of the rapid response team, that's late, right? Because that means the patient's already started to trend downward, and we may have missed those clinical cues or those trends and not had an opportunity to escalate it in a timely fashion, which would be the communication component of that.
Building on that response, what do you feel the unique role of nurses is in really preventing misses when the patients deteriorate, besides the early recognition piece?
So besides the early recognition, nurses are equipped with that clinical component, right? To be able to utilize the assessment skills, to be able to recognize changes in a patient. Sometimes for experienced nurses, that intuition saying there's something about this patient that's just not right. You can't put your finger on it, but something's just guiding you to think, let me do this extra intervention. For the novice nurse, they may not have that reference point. So they need to rely on the more experienced nurses until they have that opportunity to learn that skill set. Reporting near misses. Right? So if you've had a near miss in the past, I think debriefing is a great opportunity for nurses to come together once a bad event happens, to get together to say, what happened in this particular situation? What could we do differently? So, if that situation arises again, you're better equipped to be able to handle it. From my research and what I read, many nurses don't have that type of environment to be able to speak up, because that's suppose you had a patient that deteriorated. You need that patient to be removed from your unit, the bed, that room to be cleaned. And now you may already have another patient that's coming to your unit. So there's no debriefing or time to kind of just step aside to kind of get your clarity of thought. You're now getting a new admission. So you have to kind of put your feelings, your thoughts on pause. And there's certain areas like in the OR, they don't even talk about it. I mean, it's a taboo type of topic to even bring that up. So I think from my perspective, creating a psychologically safe environment for nurses to be able to speak about it so that they're better prepared, in the event that should happen again.
I'm so happy you use that term, because psychological safety is probably one of the things that I have advocated for my entire career, and especially during my leadership years. And I think sometimes our nurses don't feel like they have psychological safety. And so they don't feel empowered to be able to escalate a concern, or, they fear even calling a rapid response. because they don't know what they're going to be met with the nurse that comes to their aid. So, what have you found in your work and your research on key strategies to help nurses develop that psychological safety, and what approaches from a system perspective to develop psychological safety so that nurses feel comfortable in escalating changes?
I would say from the first step would be the nurse leader, because it comes from the above, then it trickles, that information gets disseminated down to the frontline staff. So I like to look at it from the macro system level, the entire institution, right? Because if a rapid response or a patient deteriorates, it's not specific to one particular unit. It could happen anywhere. It could happen in peds. It could happen anywhere within the house. So that communication would be, let's have some specific protocols in place from the CNO perspective, so that information can be disseminated down as to this is how we handle these particular situations, and give some type of scenarios. So, and I know, Vicki, you and I have talked about creating that healthy work environment, right? So creating that healthy work environment is crucial to now creating a psychologically safe environment to speak up. Nobody wants to be reprimanded or yelled at or belittled because they brought something up. And we could go from two different perspectives. That's opposed, you call a rapid response and it wasn't really needed. And they feel like, this could have been handled another way. So now nurses may feel hesitant in the future about calling a rapid response, or they're yelled at because, they went above, they may have contacted the resident on their unit and they bypassed that resident because the resident wasn't giving them the response that they need. And now they bypass them to the attending. And now the attending is yelling at that resident because the nurse didn't, follow the hierarchy. But I would think nursing should now communicate to nursing. If you have a charge nurse, escalate that to your nurse manager if you feel like you're not getting the response that you need. So I think that type of environment has to be, it can't be punitive, right? Because we've seen that if it's punitive, nurses are going to keep it to themselves. They're not going to bring it forward, and you can't improve what you don't know. Right? So I would think from that perspective, and also having debriefing after failure to rescue. I was recently talking to a nurse manager about that, and I says, if you could just go back maybe 30, 60, 90 days to see the frequency with which a rapid response was called on your respective unit. What were the types of patients that they called for, right? And then you could go back and do a little more investigation of those patients. What skill set was missed at that time, so that they can now create tailored or customized training for the nurses, because is it happening in that particular unit? Is it happening within the division? Is it happening house-wide? Right? And simulation, I think, is a perfect way of being able to get that information across in a psychologically safe environment, where people feel it's okay to ask questions. There's no stupid questions, and another way I think is to give them two different arms. You go down the failure to rescue arm, where this is where you missed the care. This is where you didn't escalate. This is where you didn't use good clinical decision making, and the outcome was mortality. And then you do the other end. This is where you followed the policy and procedure. This is when you escalated. And this is when you did what you were supposed to do, and the patient survived. So for nurses to be able to compare and contrast their interventions to see the outcome would be positive in one end and then negative in the other.
The crucial thing to me is, how do we create that environment, that healthy environment that people are allowed to learn from situations? Because I think frequently we as nurses sometimes worry that it's our fault. And that's the last thing we want to have our direct care nurses feeling, is sometimes these are system issues that lead to these points in time.
I just have a follow-up question, as it just made me think of this. How do you recommend that a nurse handles a situation where she wasn't sure if she should call that RRT or he, and the team responds and they're met with, let's say, and maybe perhaps an attitude like, why did you call this? This didn't need to be called, which really sort of shuts them down, right? And prevents them from maybe calling it when they really need it the next time. How do you, have them maybe address that or handle that?
So first thing, the nurse has to feel confident in the skills that they have. And if they're not, they should be able to now go to more senior nurse to be able to say, I'm not sure if I should call a rapid, but this is what I'm seeing with this patient, and let somebody else come back and verify for them, right?
Mm-hmm.
And then after that happens, to stand strong in your conviction that when I assess this patient, I went into the room, there was a change in the level of consciousness, there was a change in their vital signs, there was a trend where they were normal. I mean, the blood pressures was in the normal range. Now they're hypotensive. Now they're bradycardic. There's a change in the level of consciousness. The urine output has decreased. So when you start putting all these pieces together, and I think having that S bar as a framework, it kind of helps you kind of gear into very specific focal points. When you speak in that language, I think it helps the nurse with the confidence to be very specific as to what you witnessed, what you observed, and the interventions that you put in place before it happened. Communication is the key component,
Mm-hmm.
To feel that security within yourself and then have that validated by your nurse manager and also your peers. That's why I think it's very, very important to have that debriefing afterwards. I mean, I can remember years ago being a staff nurse. I mean, it's many years ago, but I could recall, and I worked in critical care and in open heart critical care. And I know it was very, very important to feel strong enough to speak to those cardiothoracic surgeons, right? Because
Mm-hmm.
it could be very intimidated because they're thinking, they know best. But the nurse is the one who's at that bedside for hours. The
Yep.
nurse is the one who has established a relationship with that patient and the family, and then making certain that you're taking into consideration what the family's telling you. I just noticed this change. There's something very different about this patient, about my loved one. Pay attention to that because they even know more than you. And then ask, what's the worst thing that happens? So if they yell at you, then, if they yell or they speak to you in a disrespectful way, that's something that your nurse manager could now take them aside and speak to them, because in the future, it's really about patient safety, right? It's not about reprimanding people because, maybe it could have been prevented. Maybe we didn't need to call you, but now we know based on what we've seen, and perhaps the next time we could do it differently. But I think simulation with communication is a key. And I do that in one of my programs. Like, have a doctor, have one of those strong doctors with that strong personality speaking to a nurse, right? And it's very easy to get frozen and thinking, oh my God, I made a mistake. Oh my God. But the physician could be making a mistake also. So it goes both ways. It's not just nursing by themselves.
I think that's great advice. And, just to continue on this track. So another issue that you identified was the struggle with clinical decision making throughout the healthcare system because of higher acuity, less resources, higher volumes, but also probably the amount of new nurses, especially the ones who were in school during COVID and maybe didn't receive the amount of training that they should have received or could have received. Could you share with our audience some of the strategies that you used to improve that clinical decision making?
That's a very good point. Thank you, Andrea, for that, because I have spoken to several managers and, there's an influx of new graduates or novice nurses coming into the healthcare system. And when you think about the pandemic, they were unallowed to go to do the clinical rotation. So everything was virtual. So we have nurses that are graduating that never saw a live patient, that never took a blood pressure, that never really had a conversation with a patient. And now you're on orientation. And to add to that, the orientation programs have been decreased. You have nurse educators that are taking more units that they're responsible for. So they may not be able to give the same level of care to those new orientees. And it's relying now on the experienced nurse. And a lot of the experienced nurses are new nurses themselves. So it's a vicious cycle right now. So what I would say to the new nurse is that there should be some type of standardized simulation training for clinical judgment and critical thinking for those nurses on orientation, right? There's a lot of literature out there that supports that new graduates and novice nurses don't recognize failure to rescue. They don't recognize when a patient is deteriorating. They never saw it before. So if you tell them to do this, they don't have any reference. They're looking at this patient in the bed and they're very task oriented. You tell them to take a vital sign, you tell them to go, but they can't put like the physiological changes and all of those tasks into saying there's something else going on. And that's where we have to use, the experienced nurses. And I think simulation is the best key. Having those unfolding case studies, and even you could take a case that you had on your unit. You don't even have to try to make it up. You could say, we just recently had a code last week. Let's take that patient history and let's kind of role play through what happened in that case and what we could do differently. I think that's the best way to learn. And then, we're still going back to that psychological safety to be able to ask questions, right? Because, through simulation, you could have a mannequin, but you don't really even need a mannequin. You could just have, this is the case scenario. These are the vital signs. You walk into the room, right? And have that nurse say what they would do for that patient. So they're having an opportunity to use their critical thinking and their clinical judgment there, and then have, the nurse manager or the nurse educator there to be able to say, well, what else? What else can you do? And then, try to formulate that type of thinking within them.
I think it's fabulous advice, because what I hear you saying is, this is totally Patricia Benner's novice to expert, and they're really in this novice phase where they are in this black and white thinking, and all of these simulations and case studies can really propel them through each of those stages to get to at least competent and proficient. So I think that's fabulous.
And then if you're doing it in real time, right? So if you're doing it like after, like a patient may have expired, or patient didn't expire, but the patient now is on a med-surg unit and now was escalated to the ICU, right? You could see what happened that we could have maybe prevented that patient from going, because patient could go to the ICU and it turns out they stabilized the patient. The patient really didn't need to be there, right? So now you're escalating them to a high level of care, but now having that communication with the intensive care unit as to what care that patient received, and then bringing that information back. That's what I think that's missing, that training and that actual hands-on and the talking through it. Right? Because I know if you talk through it, but if you write it down, you're going to take that piece of paper, it's going to go in your locker, it's going to go in your bag, you're never going to see it. But if you actually are talking it through it stays in your memory.
Well, and I think the other fascinating thing that happens during those situations is you often see that there's multiple points where things happen. The burden doesn't rest on one person's shoulder. It's
Correct.
usually a system issue that has led to this. I know you've worked with several teams with your methodology and your training programs, and our listeners love stories. Is there a particular success story that comes to mind that you'd like to share with our audience?
Yes, I could say that I've been had a focus group of nurse managers, and they were asking some of these very same questions, because they do have a lot of new nurses on their unit, right? And a lot of the experienced nurses had left. So I was giving them some tips, some of the things that I just mentioned, and they actually did a pilot study on one of the units, and they were able to reduce the number of rapid response to their unit. And the nurses were very appreciative, and they said that they really learned so much in that control setting, because they had them go to like a classroom and they work through some of the issues that they had experienced. And I think the key thing is just feeling comfortable enough to ask a question, right? I remember the first time I had a patient when I was a new nurse die, and I thought that was like the end of the world, right? I thought like, oh my God, how am I going to go through this? But then when you think of the steps of what you could do to prevent that, and you equipping them with that confidence that you could do this, right? It's really having that active listening skills, right? And then looking at your patient, seeing if there's something different. The other key thing is the documentation, right? So if nurses come on a day shift, they see their patient, they do their assessment, they make their rounds. Depending on what type of unit that they work on, they may only have to do vital signs every 4 hours, every 6 hours, every 12 hours. So what's happening in that off time, right? So that's why report is very, very important. Who else do you have on your unit that's working with you? So they also have eyes to go in and check on that patient. And then even when the family's at the bedside, you could educate them to say, there's a change in your loved one. Make certain if the person experiences this, you're letting us know. So it's not only the nurse that's responsible, and the doctors, right? The doctors make their rounds, the teams make their rounds. I think you need open communication amongst the entire team, but they said that they looked back over 3 months, and they were able to reduce the number of rapid response by doing the training with their nurses. And they have debriefing, like they would have like
Yeah,
a debriefing, in the morning.
that's awesome. They were able to take those skills and put them into practice.
So, lastly, we would really like to end our time together on a fun note. So, we have heard that in your work to promote patient safety, you introduced a Shark Tank experience. So, we would really like to hear about how this worked and if there was a particular Shark Tank that maybe stood out more than another one.
I actually was in the Shark Tank. So I'm a member of the National Nurses in Business Association, and they had their annual conference this past summer in Florida. They had stopped it during the pandemic, and now they were resuming having this Shark Tank competition. So I had submitted my application, and you had 5 minutes to present your pitch. There were 3 judges. The 3 judges had a series of questions to ask you. They had 5 minutes to ask those questions to you. And then you went on, then they were able to announce who the winners were. So there were 5 contestants. I was the 5th contestant. And I had rehearsed my pitch. So the 4 programs that I had referenced earlier, I bundled those together and called it High Value Care, My Story, Patient Safety Bundle for Nurses. So I grouped them all together. So here I am now in Florida, and I'm on stage, and they actually put the Shark Tank music on when you walked on stage after they introduced you. I had 200 people, nurses at various stages of entrepreneurship in the audience. So 200 nurses, and then I didn't have any notes. I had rehearsed it. I kept looking in the mirror because you only had 5 minutes, and they were very certain that these were the key things that you had to include. They wanted to know the innovation of your pitch. They wanted to know who were your competitors. They were sure that there was somebody else that could have created something similar to what you're creating. So you had to explain what's your value composition, why somebody would want to come to you versus someone else. And you had to incorporate that into your 5-minute spiel. So I thought it was it was a lot of fun. What it worked for me was it gave me the opportunity to really be very, very specific who my target audience was. Because if you only had like 5 minutes or a minute, like an elevator speech, right, to say, what do you do? It gave me that opportunity to really lean into that. And I knew that in order to make change for patient safety at the bedside, the frontline staff, the mesosystem level, right? I needed to get to that. I mean, the microsystem level would be the nurse. The mesosystem would be the leaders, right? So in order to get there, we have to think of the well-being of the leader, right? Because if we're not thinking of the well-being of the leader and the healthy work environment, all these other components fall to the side. So I thought it was very, very important to focus on the leader first, right? Because the leader now could be a role model for their staff and having those communication skills and create an environment where it's okay to speak up and to share your experiences. And leaders were having their own issues. I mean, if you look at the literature, there's so much evidence of what we could do for the nurse, but not so much what to do for the leader. So that's why I focused on them first, and then to be able to incorporate these other components. And when I asked in the room, do you know anybody that's ever went into a hospital and did not have a positive experience? And somebody knows somebody that this may have happened to, and what can you do differently? And it's also being an advocate for patients, families, to be able to speak up and say, oh, I thought there was something different about this person, but not speaking up. You're educating the family and you're educating the staff. I wasn't selected as the winner per se, which was fine. But I did get 2 coaching sessions from the Shark Tank judges. And what they had advised to me was, you really need to pilot this whole program so that I could get data and I could publish it. And that's where I am right now. I started the pilot last week, in which I had said earlier, I had 12 nurse leaders that are going through the 4-part series. And I'm going to have 75 nurses go through the other 3 programs. So I'll have 3 cohorts of 25 nurses that will go through the other programs. And I'm also using the Healthy Work Environment team tool. They get that next week when I present. So I'll be able to collect a lot of data.
I think you touched on an important thing that I just want to call out is nurses are the best ones to solve some of these problems as innovators. And I think understanding how we can make our elevator speech as a nurse is so critically important, so that when we're in front of those right audiences, we can pitch that elevator speech and make a difference. So I just want to remind our audience that keep those ideas coming because we're the ones that can solve those problems. But Yolanda, we just want to thank you so much for taking this time with us and sharing your story. It's inspirational, and I know you're just really starting this journey, and I can't wait to see where it's going to lead to. And your incorporation of our healthy work environment standards is just incredible, and I think will, be icing on the cake that you're creating here.
Thank you, Vicki and Andrea, for inviting me to be a part of this podcast. I really enjoyed sharing my story with your members and your audience, and this was a wonderful experience for me. Thank you so much.
Thank you, Yolanda, for sharing your deeply personal and inspiring story with us and our listeners. I'm excited to see where you take this journey next. Thank you as well to our listeners. Be sure to subscribe to our podcast using your favorite streaming platform. We would love to hear your feedback on this episode and your ideas for future episodes. Please send your thoughts to podcast@aacn.org, and we will see you next time. Bye-bye.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills.